I'm curious if we know performance rates of a QCDR versus a QR. We are wanting to do a cost benefit analysis of each option.
Great question, Becky, and it's a valuable concept. You're essentially asking if I'm delivering great performance to my patients. Is QR or QCDR more likely to appropriately reflect that high performance in the submissions made on my behalf? Unfortunately, I don't know of any way to get to that comparison. Historically, in the PQRS system, that is the physician quality reporting system that preceded MIPS, if you can remember life before MIPS, Medicare did do a comparison of the mechanisms in every year's annual feedback report. However, that's old enough now. I don't know that we can rely on that, and it really looked at number of measures rather than comparative performance. So again, didn't answer the question you're asking. Now, there is some indirect data comparing ECQMs to MIPS CQMs. Nearly all ECQMs have an equivalent or near equivalent measure in the registry MIPS CQM measure set. Medicare sets annual benchmarks based on performance rates received and observed in annual submissions. Benchmarks are typically lower for ECQMs than for MIPS CQMs, meaning the performance scores are routinely lower for ECQM users than MIPS CQM users. Now, there could be a common cause. Factors that lead to the adoption and use of ECQM measures could also predict lower real performance, but I theorize that understanding the nature of documentation standards and workflow requirements, the requirements of the mechanisms to be populated, I suspect that equivalent performance is falsely downgraded by the strict measurement requirements and comparative lack of flexibility represented in ECQM systems compared to MIPS CQM systems. But there's no such comparison between QCDR and QR processes. They use the same specs, the rules grant them the same flexibility, they share benchmarks. The observable differences are in capability, flexibility, and measure choices offered by those vendors serving each of those mechanisms. QCDRs are likely to have fewer choices, less flexibility, and fewer capabilities than QRs. QCDRs generally specialize in a single specialty. They draw clients from a subset of practices and providers nationally, just those in the specialty they serve. QRs, being generalists, draw from the entire pool of practices and providers nationally. Additionally, if you are a single specialty group, a QCDR tending to be specialty specific is more likely to meet your needs than the more varied needs of multi-specialty groups. Considering the variety represented in the existing 12 MVP specification sets and extrapolating forward to an aggressive MVP development process, I expect to see all measure types represented indefinitely going forward. Particularly if yours is a multi-specialty group, you're likely to ultimately need mixed submissions drawing on multiple mechanisms. Good luck. It's going to be an exciting ride watching MVPs being implemented.